by the Partnership for a Connected Illinois. My name is Nancy Kazak. I'm director of the Illinois Telehealth Initiative, which is a project of the Partnership for Connected Illinois. A couple of business items. We wanted to tell you that if you have questions during the event, you go to the Q&A box, which you can see on the lower right-hand side of your screen. We will be taking a survey after this event, so you can give us feedback on your thoughts on this and other future topics that we can explore. And there will be a link to the recording sent to all the attendees, so you'll have access to hear this all over again or share it with your friends. We'd really appreciate that. Today's forum will be focused on the title, Envisioning the Future of Telehealth, Policies to Ensure a Continuum of Care for Mental Health and Substance Use Disorder Patients. We're very, very excited about the work that's been done in preparation of this. I wanted to give some credit to the people who have just made this happen. First of all, the Upper Midwest Telehealth Resource Center has been spectacular. Autumn and Becky have just been wonderful in putting this together, so kudos to them. I also want to thank the TASC, Treatment Alternatives for Safe Communities, Michele, Worobiec, who's been the prime organizer of this. You've done a spectacular job, and we're very, very excited. We have 12 organizations that have been promoting this event to their membership and to others. And I want to take us just a second to give you the names of those organizations so that you can be aware of who has reached out. There's the Association of Community Mental Health Authorities of Illinois, Chicago School of Professional Psychology, Connected Health Initiative, the eHealth Initiative, the Great Plains Telehealth Resource Center, the Illinois Association of Healthcare Attorneys, the Illinois Critical Access Hospital Network, the Illinois Health and Hospital Association, the Illinois Psychiatric Society, the Illinois State Medical Society, the Mental Health Summit, and Southern Illinois Healthcare. We could not have done this without you. And as a result of their great work, we have over 300 people signed up to participate today, and we really appreciate it. I also want to thank the speakers. We have some spectacular speakers today, and our panel is going to be just very enlightening, and we really want to thank them for their work. And particularly, we also want to thank the frontline workers who've been working so hard over the last 4 months and keeping things together and providing folks the mental and behavioral health and substance use disorder help that they need during these very, very critical times. We want to extend our thanks to them. And then I want to thank you for attending. Thank you for taking time to learn more about this and to help us look to the future of what happens post-pandemic and how we can continue to care for folks and how we can care for them now and care for folks in the future. So with that, I'm going to introduce Michele Worobiec, who is going to be the moderator of our program. She's Vice President and Chief Counsel for TASC. She's also, I want to say, I used to think that I was the most organized person I know. I've been put in my place by Michele. She's absolutely superb at organizing this. She's a recognized expert in the development and implementation of juvenile justice interventions for people with substance abuse and mental health conditions, from pre-arrest deflection to court-based interventions to community-based post-incarceration programs that reduce recidivism. Michele, in her prior life, comes to us from Ohio, where she was a judge on the bench in Ohio for 7 years, and she presided over criminal and civil cases, as well as drug, mental health, and veterans courts. There, she advanced the position of policy counsel for the Supreme Court of Ohio. So we thank Ohio for letting Michele come to us, and we really appreciate all the help that she's been. And with that, I'm going to turn it over to Michele.
Well, Nancy, that is quite the introduction. I hope I can meet all the expectations today. And I will also extend my thanks, Nancy, to you. You've been wonderful to work with, to help foster this idea and to make sure that we're well supported and well developed. And you have an amazing expert committee that was able to help us develop some of the substance that we wanted to share today. So I appreciate your work on behalf of the Illinois Telehealth Initiative, as well as the Partnership for Connected Illinois. And Autumn and your colleagues at the UMTRC, we really appreciate how easy you've made this for everybody. You know, earlier this year, our nation was thrust into an unplanned and comprehensive telehealth pilot. And basically it was an opportunity for telehealth, or for healthcare providers to roll out or expand telehealth services. And that's not usually how things are done. And but we were given this opportunity, and by all measures, it's been extremely successful so far. Data from the Centers for Medicare and Medicaid Services indicate that the remote visits for Medicare patients have increased from about 12,000 a week before the pandemic to more than 1 million telehealth visits per week currently. We're also seeing that about 460,000 Medicare beneficiaries, or about 60% of that population, are receiving mental health services from a psychiatrist or a psychologist through telehealth. And telehealth has been cited as a great promise for mental health clients who, for many other reasons, may also feel more comfortable receiving services via telehealth because of stigma and seeking out in-person care. At the highest levels of the government, we have indications that telehealth will continue. HHS Secretary Alex Azar said earlier this month at a Hill event that he supports expanding telehealth provisions that were lifted during the epidemic. In fact, he said, "I think we'd have a revolution if anyone tried to go backwards on this." And he indicated, quite frankly, that this is now, I think, an embedded part of our healthcare system. So what brings us here today is the opportunity to advance the conversation. Early in the pandemic, there were webinars and forums to help us first understand the technicalities of emergency orders, which allowed us to do this expansion of telehealth, and also to give advice and to share experiences and how we were able to quickly transform healthcare delivery to a remote setting. Today, we are offering all of our participants, of which there are many, and we appreciate your participation, to have a seat in this conversation, to envision the future of providing a full continuum of care for individuals with mental health and substance use disorders via a telehealth platform. So as Nancy already indicated, we have a panel today. We'd like to divide our time about half of the time spent in a panel discussion where we have some topics that we felt the need to share. And then we wanted to shift over into a question and answer session. We already have some questions that were submitted in advance, and we welcome for you to submit additional questions for us to address in the chat box. So at this time, I would like to invite each of our panelists. I'll announce you one by one, and I will let you give a bit of a self-introduction. And so we'll start off with David Applegate, who's the Director of State Policy at the Kennedy Forum of Illinois. David?
Thanks, Michelle. So again, my name is David Applegate, and I'm the Director of State Policy with the Kennedy Forum of Illinois. For those of you who aren't familiar, the Kennedy Forum is a nonprofit organization founded nationally by former Congressman Patrick Kennedy, and in Illinois by a group of civic leaders and behavioral health advocates. Our mission broadly is to eliminate stigma and discrimination against people with mental health and substance use disorders. In the context of public policy, this has meant a focus on mental health parity, discriminatory policies and practices in health insurance, and ensuring that everyone has access to the mental health and addiction treatment they need. In our efforts to advocate for increased access to treatment, we have increasingly gotten involved in the telehealth policy space, particularly in recent months with COVID-19. When it comes to telehealth, it's all really about access to healthcare and the ability to take advantage of telehealth as an option to receive MHSUD treatment. So there's lots of public policy considerations that are a part of this that we will discuss today, but I think it's just important to always ground the conversation and access and how telehealth is one mechanism we can use to increase access to healthcare and mental health and addiction treatment specifically. So I'll leave it at that for now. Thanks for having me here today. Looking forward to the conversation.
Thanks so much, David. Next up, we have Heather O'Donnell, the Vice President of Advocacy and Public Policy at Thresholds. Heather.
Thanks, Michelle, and thanks for inviting me to participate. My name is Heather O'Donnell. I'm the Senior Vice President of Public Policy and Advocacy at Thresholds, which is a 60-year-old community-based mental health and substance use treatment provider in Chicago and the surrounding counties. We serve people who have some of the most serious mental health and substance use conditions. Most of them have a history of homelessness because of a lack of access to treatment and housing. They cycle in and out of the criminal justice system. They live in extreme poverty, and many of them were disabled many, many years ago because they didn't have access to treatment. So my comments are coming from that vantage point. And really, I'm just excited to be part of this discussion because it's really all about access to treatment, whether it's through telehealth services or in-person services. And this is just another way to expand access.
Thanks, Heather. We're glad to have you. Next on our agenda is Marvin Lindsey, who's the CEO of Community Behavioral Healthcare Association. Marvin.
Thank you, Michelle, and also thanks to the Upper Midwest Telehealth Resource Center and your agency, TASC. And a special thank you to Nancy Kazak, who I call the mother of telehealth. I have been working with Nancy for about 4 or 5 years, and she has really pushed telehealth in Illinois. As Michelle said, I'm the CEO of the Community Behavioral Healthcare Association. We're a trade association of over 90 community mental health and substance use providers. Our members provide a variety of mental health and substance use prevention, treatment, and recovery services. And I believe they serve close to around 60,000 people every day. Our members are considered the safety net providers. Their funding is mainly consists of Medicaid, some state grants, and some commercial insurance. Prior to COVID, our members provided 90 to 100% of their services were face-to-face. They operated under Administrative Rule 140, and their reimbursement guide, the HFS Community Behavioral Service Provider Handbook really dictate how those services could be provided. One of the delivery modes in that service is phone and video. So as we will discuss, that equals telehealth. But the biggest barrier to providing those services from our perspective is individuals receiving telehealth mental health services had to receive the services at a certified Medicaid site. As you know, and we'll talk about it, that has been lifted. Also want to mention psychiatric APNs were not listed as appropriate to provide telepsychiatry via Rule 140, which we still believe is a barrier to services. So the pandemic hit and the governor declared a proclamation on March 9th, followed by an executive order to expand telehealth services. And our members went from 90 to 100% face-to-face to about 90 to 100% telehealth, literally overnight. And so that is where we're at now. And we have learned some things over the last 4 months, which I hope to share in our conversation today.
Thank you, Marvin. And we also have joining us today, Robin Fretwell-Wilson, who's the director of the Institute of Government and Public Affairs for the University of Illinois System. Robin?
Yeah, thank you for having me, and thanks to TASC and everyone for making this possible. I think I'm the utility infielder here in the sense that I'm not a healthcare provider directly. Don't really have a dog in this hunt, but have been watching telehealth over my time as a healthcare law professor. So that would be now 20 years. And then have done a tremendous amount of work in state houses, trying to get sort of positive policy change in a number of the healthcare realms. It's exciting to be here at this moment. I've recently become the director of the University of Illinois Systems Institute of Government and Public Affairs. It's a 73-year-old shop that has been in the process of sort of taking ideas about policy change out of faculty scholarship and into the real world. And I would see telehealth as one of those places where if you can manage to get the policy changed along with the actual cultural shift and practice shift that you have seen in the short space of time in COVID, if you can sustain it, I think that's super exciting in terms of opening access to communities that have been underserved. So I'm here really to kind of think with you about what those policy changes are and how they would get done. So thanks for having me.
Absolutely. Thank you, Robin. And let me say a few words about TASC. As Nancy indicated, it stands for Treatment Alternatives for Safe Communities. And telehealth is actually fairly new to us due to these emergency orders and allowing us to expand this means of service delivery. We deliver specialized case management, which is a comprehensive way of looking at referrals to us that we receive from the justice system, both the adult and youth court systems, police, corrections, as well as child and family services. We look at both the strengths and needs of our clients. We take into account their clinical diagnosis as well as their ASAM level of care for substance use disorders. And we work with them on determining client-centered service plans. We continue to make sure that our clients are fully engaged in all the services that they need and they're working well, and we make adjustments to the service plans as needed. Because that is our focus with our clients, we spend a lot of time removing barriers of access for our clients to the things that they need. And so it's been a real privilege to be able to work with telehealth, both as an agency and also making sure that we can continue the ongoing success and learn from all the lessons that we've been encountering over the past several months. So with that being said, I'd like to kick off our first topic for conversation. I mentioned a few moments ago and characterized telehealth a little bit differently. Oftentimes telehealth is referred to as a service. The way we've been looking at it at TASC and other agencies as well is that telehealth in and of itself isn't a service. It's a way or a means that services are delivered. Heather, would you like to kick us off and talk a little bit more about telehealth as a means of service delivery?
Sure. I mean, all of this is really about access to care. I think everybody really talked about it in their introduction. And we know that we don't have an adequately funded mental health or substance use treatment system, and that the vast majority, fully 2/3 of people who need treatment in Illinois don't get it. They don't get it because it's not accessible. There's also stigma issues. But the main thing is that we don't have enough access to care, and we have enormous human tragedy because of that. If you look at sort of the racial disparities in access to care, Black Chicagoans are dying from opioid overdose at a rate of nearly 2 times the rate of white Chicagoans. We have elected officials that are calling our jails and prisons our new largest mental health and substance use treatment facilities. I'm not sure about anybody on this webinar, but I'm not sure anyone would choose to go to a jail for treatment. They are not healing treatment environments. We have huge swaths of the state and the country they don't have a treatment professional within, an hour, sometimes 2 or longer driving distance. So access to care can be very, very limited, and telehealth is a mechanism to bring care to that person when they are in their home or they are wherever they are. So this is not an additional service. It is a way to bring the services to the person. And if we did not have telehealth in this pandemic, there literally would be no way to provide mental health and substance use treatment except for in extreme cases to the thousands and millions of people across the country. So this really is about access to care, and in my opinion, really sort of modernizing how we deliver healthcare. I mean, most of us, our modes of communication are electronic the vast majority of the time. We should be harnessing that for mental health and substance use treatment as well as other medical care.
Excellent. And I think you've really hit the nail on the head. A lot of the discussion that we had as a group before today talked about access to care, and telehealth in some respects has dramatically increased access to care. And we've also acknowledged that the access that telehealth provides now is not perfect. And we've also noted that even telehealth has been expanded. So I'd like to unpack those kind of three big topics a little bit further. And I'll turn to Marvin to help kick off. What is working well with the current expansion of telehealth?
Yeah, thanks, Michelle. Yeah, our members have been providing telehealth for a good amount of time. Like we have a couple of our members in particular that have been doing telehealth services for about 15 years. One of the big barriers in providing that has been the ability for providers to be able to do telehealth services in the home, okay? And so while we look at our members, some of the things that are going right now let me say that our members are community-based mental health service treatment centers. So they're not individual providers, just so you get an idea of who I'm talking about. They're, according to them, and this is preliminary data, we're going to take a survey in a couple weeks to get at a lot more of what I'm getting ready to talk about. But preliminary, it says a significant increase in client engagement and reduced cancellations. We're also talking about client comments that they feel safer accessing care via telehealth, especially during COVID. And this especially with people with co-occurring health issues. Telehealth has also been able to remove transportation barriers for low-income families, particularly in rural communities where services might be 20 to 30 miles away. And also working adults or working clients. One of the things that I heard recently was from one of our members who had a client that was a farmer in Southern Illinois. And he wasn't able to make his appointments on a regular basis because he was driving a tractor and he was in the fields, and And currently, with telehealth in place, he hasn't missed one appointment. And so that says a lot about with some populations that telehealth is working. And we'll talk about what populations it might not be so good for telehealth, but there are some populations that it really works. And also it reduced burdens on childcare for single parent households, especially those who are, again, employed. So I can talk a little bit about what we've learned from the client perspective too, Michele, but I'll hold that off for now because I know you have some more questions.
Sure. Well, before I ask more questions, I know all of you have touched upon telehealth. What are some other things that are working well from your perspective that we want to make sure remains in any future iteration of telehealth? Remembering that with these executive orders, our previous version of telehealth was significantly expanded. So it's important to note those things that are working well and should remain on the table as we move toward a more permanent structure in the future. And let me throw out one thing, kind of building on what Marvin said. You noted in rural areas, it helps to bridge gaps, certainly for working parents. Telehealth previously had to be more of a means of last resort. And I think, Marvin, part of what you're describing is now it can be available for convenience as well. Would anyone like to comment on that shift?
I can comment on that a little bit. I want to piggyback off of what Marvin said, just in thinking about it kind of intuitively, is that one of the primary benefits of telehealth is the flexibility that it allows to the patient. And when we talk about location, previously, as Michele, you're saying, like there was not a lot of flexibility around the location of the provider and the patient. And that kind of defeats the purpose in a lot of ways of telehealth. The whole purpose is to allow for to receive your care remotely. So I think that's been like a huge advancement that we want to, in the past 5 months, that we want to see move forward. Another thing with regards to flexibility for patients, and I think other folks are going to talk about this, is around the technology that we use and allowing broader and more liberal uses of the types of technology that that we allow folks to receive healthcare via, and that providers are able to deliver via.
Very good. And speaking of technology, some of the expansion of telehealth has gone now beyond video, which is what individuals have previously thought of as telehealth, into audio only, and even texting, including synchronous texting. Any panel thoughts on the need to continue to include audio telehealth as well as texting services?
So I can talk about that a little bit. So as I mentioned, most of the individuals that Thresholds serve live in extreme poverty and oftentimes have very challenging lives. And this really relates to the social determinants of health, that not everybody has access to iPads and computers and smartphones. A lot of our population, they have government issued cell phones, they have a limited number of minutes, and they simply just don't have access to video. And I think that this was eye-opening for many policymakers. I think it's so common that people think that everybody has access to smartphone technology or other kinds of platforms. And this just simply isn't the case with people whose lives are chaotic and they simply live in poverty. So I think making sure that we continue to have phone only telehealth is really important. I will say, though, that this can be very challenging over an extended period of time for people with serious mental illnesses, as well as substance use conditions. I think there is a little of telehealth fatigue in this environment because it's really been the only way to engage in services and for people to go from completely in-person services to completely telehealth. I don't think that is probably going to be a best practice once we get out of this pandemic. But I think we need all modes of communication available to provide services. And it's really, I think, what the client is how the client is most comfortable and able to engage in services. Those modes ought to be available. And I also think that one of the things, particularly in the substance use world, that we need to think about is in Illinois, and I think Marvin alluded to this, that services are nearly solely site-based in Illinois. So for people struggling with addiction who maybe are not abstinent yet, but still have very chaotic lives and are trying to help themselves, if they have childcare issues, if they have transportation issues, if they don't have enough money to get on public transportation to get to services, telehealth offers them an opportunity for recovery support and sort of wherever they are in their recovery journey. And we need to harness that. And then another thing we need to think about is the site where the clinician is. Currently, I believe the clinician has to be within the substance use treatment site to be able to deliver services. I just think that we need to, as we advocate for telehealth, we need to think about really how is the best way to get the person the services at that very moment they need them. And sometimes those are off hours. It can be very late at night. And people aren't in their clinical space. So those are just some of my thoughts.
I appreciate those. And actually you mentioned about the audio services, and there was a statistic released by Seema Verma just a couple weeks ago, July 15th, that nearly 1/3 of beneficiaries that received a telemedicine service did so using audio-only telephone technology. And I think some of the experiences that you've shared really reinforce what we see at TASC and the service providers that we connect with. It's not just the pandemic, which obviously is keeping all of us home, as the audience can see from our background, that there are a lot of reasons to continue utilizing telehealth, even when it could be possible to go to a provider's site. It's just not practical for that particular client. So thank you for articulating those reasons so well. Marvin, in your introduction, you talked about, you also had some comments about things that are going well from a client perspective. Is there anything that you had in mind that you wanted to raise that we didn't already have a chance to discuss?
Yes. In my research in preparation for this forum, one of the things I did was talk with my colleagues from around the country in different states that also represent community providers. I talked to Ohio and I talked to association in Maryland. And in Maryland, they looked at telehealth and how it brings down barriers to care. And here I'll read a couple of the questions and responses that they gave. If telehealth remained available after the pandemic, would you prefer to continue using instead of in-person visits? These were asked of about 4,000 clients. And 70% said that they would use telehealth for half or more of their visits. And some of the comments were, it's just hard to get to the office. Weekly, it take me 2 hours out of my day just to get there and back. Another question was, please identify the reasons you may wish to continue telehealth services. The number one reason was reduce exposure to COVID. That was 67% of the respondents. The next one was appointment flexibility. And after that, it was travel time and transportation. So when you look at this survey, you can see how with some clients, it benefits them to have telehealth. And I also want to make the case that and we could talk about this, but for some clients, it does not, benefit greatly or at all. And so another question that Marilyn asked clients was, how connected do you feel to the therapist, case manager, or individual providing services through telehealth? And 51% of them said the same. 16% said not as well, and 13% said much better. So again, you know, we're looking at telehealth as a response to not only access, but for me and SEBA, we're looking at it as a response to the workforce challenges that we have in Illinois also, which I can talk about in a few.
And we will absolutely be transitioning to that topic in a little bit. All right, now I want to pick up on the topic of access, which Heather, you helped focus our attention on early on. And I think a number of panel members have acknowledged that clients don't all have internet access. So I just wanted to share, recently Mayor Lori Lightfoot indicated that the internet is one of the most powerful equalizers we have. Governor Pritzker last year signed into law 2 massive statewide infrastructure plans, including Rebuild Illinois, dedicating $400 million to increasing high-speed internet connectivity across the state. And an additional $115 million this year from state and matching funds is funding Connect Illinois broadband expansion, with a goal of creating near ubiquitous broadband access across the state. So we know broadband is an issue, and I'm going to give Robin a heads up that we're transitioning the conversation over to her. So I would like to hear your comments on the topic of broadband access, and also maybe some of the other barriers the clients are experiencing that are limiting their access to telehealth.
So I think that was a kick over to me, Michele. So look, let me just first go back to a point that Marvin made that I thought was really helpful, and I'd love to sort of engage on more in terms of the provider-patient relationship over these different platforms. And I thought it was interesting to focus on how connected the patient feels to the provider in that instance. And I think we should think about whether there's an existing relationship. I think it would be hard to form that connection at the first moment. Maybe telehealth has a wider role to play when there's already an existing relationship, as opposed to someone being seen newly. On the digital divide, IGPA has done some work. We created a task force at President Kaleem's request on the impact of COVID on the state. And one part of that task force was looking at community and family resilience. And we drilled down on the fact that the digital divide makes it very difficult for lots of people to use. I see David shaking his head. Thank you, David, about that. But, very difficult for them to use some of the resources that we're using right now just to talk about this issue. And so even though I think, Heather made a very compelling case that you're going to have a wider set of folks that you can bring in because you lower some barriers. At the same time, we're increasing barriers. If this has to be through a video feed, or even to some degree, if it has to be through a phone. So, those are divides that I think we have to pay attention to and ask. And it's more than just the broadband access. I know we've thrown a lot of resources. I think COVID really has focused our minds on what a massive chasm this is between the haves and the have-nots digitally. But it's worse than that, right? It's not just, broadband, it's your device, right? So do people have, a laptop? Do they have an iPad? Do they have a smartphone? And you know, one of the things that we focus on in the task force report, which you'll see in chat here, a link to it, is, you know, there are federal programs that, you know, will drop ship you a phone if you qualify for certain federal assistance. And they suspended some of the income rules during this time period of COVID for that. So that helps us get more devices in the hands of people to be able to access these services. But I think it's a sticky problem that we have to continually pay attention to if we want to make a shift to telehealth and away from, you know, physical visits.
Thanks, Robin. Excellent points. Is there anyone who'd like to tag team on some of your observations about the barriers that still remain with telehealth that need to be addressed as we envision its future?
Well, one barrier, Michele and Robin touched on it too, was just broadband. As I said earlier, Nancy and I were on the governor's telehealth work group for Illinois Connect. And one of the statistics that I've seen in that work group from 2018, which is not that long ago, from the FCC is 581,000 households in Illinois do not have any kind of internet service at all. You know, for somebody like me who just take it for granted now, you know, that I have a cell phone or internet connection, it's over 581,000 people do not have that access. One of the things that has been happening lately is a $50 million grants that went out to different internet broadband providers across the state. And I believe in our handouts or resources, we have a map that shows where some of that money ended up. I know with some of our members, and particularly in rural communities, they have a hard time in engaging a client in video because of the lack of connectivity in that area. And so some of those areas that have been identified in that map that you have will hopefully start to see that pretty soon. The governor has appropriated about $420 million over 5 years for broadband. As far as I'm concerned, it's very much needed, not only in rural communities, but also in urban communities in different parts of the West and South Side of Chicago and East St. Louis and other places, Rockford and other places where there's a need. So I think that is also one of the barriers that we're seeing.
David, it looked like earlier you wanted to jump in on the barrier question. Is there something that you wanted to add?
You know, I forgot what I was going to say at that time, but Marvin just mentioned something that made me think of another issue. And that's that I think a lot of folks kind of look at this as a rural issue oftentimes. And I think that telehealth, I don't know if this is necessarily a barrier to telehealth in and of itself, but telehealth, a barrier to mental health care a lot of times in communities of color and urban communities is lack of access to culturally competent care and lack, I think it's something like 2% of psychiatrists, for example, or 4% of psychologists are Black. And I think that telehealth offers an opportunity to overcome that barrier. Just in some of my research, there are actually platforms and companies that are out there now trying to, that are for the sole purpose of connecting patients with a provider who is culturally competent or might have a background that reflects their life experience. And so when we talk, this isn't necessarily, again, a barrier to telehealth, but just in a barrier more generally that telehealth can help overcome. I think that's an important thing to consider.
Thank you. That's an excellent point. I'll raise a point also and throw it out to the group for further development. As I mentioned before, we do comprehensive specialized case management at TASC. So we're looking at treatment needs. So quite clearly, substance use disorder diagnoses as well as diagnoses for mental illness, and making sure that our clients are fully connected to and engaged in treatment of whatever means for those services. But treatment alone is not going to help stabilize individuals and help them be successfully acclimated in their communities. So there's a lot of talk about social determinants of health, education, employment. I've heard transportation, childcare, some basic needs. We're even looking at food insecurities right now as we have and increased unemployment. So how does telehealth help implement or help support some of those social determinants of health in ways that telehealth before the pandemic opened it up, didn't give access to?
One of the things that I can mention is that I was having a conversation recently with somebody who has been doing telehealth during the pandemic. And the clinician said that it was really, this is a clinician that doesn't do community-based services, but that did mostly office-based work. And they talked about the value in being able to see the person's home in the background and just get a better feel for the person's environment, which gave them a different kind of understanding of maybe some of the challenges the person was facing related to the social determinants of health. So I think it can provide maybe a different window into an individual's life that maybe is not present in an office-based setting, that can maybe help the clinician or the case manager or other person doing telehealth, that can maybe give them some insight into how to respond.
Heather, that's an excellent point. I think we've seen that as well. And in doing some research on telehealth, one of the things that's noted, not only in behavioral health circles, but also in medical circles, is that telehealth allows more frequent and briefer opportunities to contact clients. And so whereas in a traditional office-based model, you might not see individuals as often, if someone isn't going through some kind of a short-term significant insecurity or crisis, the ability to touch base if needed daily. We have a high-intensity case management that we use for individuals that really are in a temporary crisis situation that is much more easily accomplished through a telehealth platform. One other thing that came up earlier that I want to make sure we don't lose sight of is credentialing requirements that were imposed upon in telehealth prior to the pandemic. And I know I had mentioned that telehealth really isn't a service that would require separate credentialing. It's a means for professionals that are already licensed and credentials to do their professional services to utilize another means of reaching out to clients. So I guess addressing credentialing and also, in light of workforce shortage, Marvin, you had some comments related to that you wanted to share.
Yeah, our association over the last 3 years have chosen out of necessity workforce shortages as our #1 policy issue. Right now, Illinois behavioral workforce situation is at a crisis state, and the lack of behavioral health strategy is exacerbating the problem. So one of the things that we did was in 2018, we wrote a resolution that passed unanimously by the House that declared a behavioral health emergency at that time. We followed that up with another piece of legislation that looked at developing a behavioral health workforce center task force. And that passed, and over the year, from 2019 to during the year 2019, we formed this task force, which developed a report. And the report, which you have in your resources that we're going to share, aim to not only highlight the behavioral health workforce shortages, but also talk about different solutions to the behavioral health workforce issue in Illinois. One of the things that I'd like to just point out is the Kaiser Foundation estimated that only 23% of Illinoisans' mental health needs are met, and I believe Heather touched on that. And those shortages are really more acute in rural areas and among low income and underserved communities. And so what the task force decided to do was offer some recommendations. And one of them was to create an Illinois Behavioral Workforce Center, Education Center. It will be based off of a center that's currently is housed in Nebraska. But what we're looking at here is to put Illinois spin on it that is really looking at providing a way for Illinois to develop a strategic plan around retention, recruitment of behavioral health workforce, and also training. One of the other recommendations of the task force was also to establish resources to develop an infrastructure available to support and coordinate behavioral health workforce development efforts. And resource being money. I mean, it's going to take some money for this to get up and running. And another recommendation was to expand programs or service modes of services delivery like telehealth, which we looked at as that can expand the reach of the existing workforce. And I think that's what we're seeing now. And we also wanted in our recommendations to improve training of behavioral health workforce professionals in telehealth techniques. One of the things you talked about, Michele, when we first got started was that this was just a pilot. And in any pilot, you want to learn something from it. And one of the things that we're learning is that people was just kind of, thrown into it out of necessity. And now I know our members are putting in policies and other trainings over the last 4 months to really address those things that haven't been, that are needed. So we still look at workforce issues as very important, that it is a crisis, and we look at telehealth as being part of the solution towards that.
Thanks, Marvin. You talked about financial resources, and that is obviously one of the necessities to continue to have telehealth become a permanent fabric of all of the services that we provide. So David, I'm going to ask you to help lead off the discussion about how payment adaptations have contributed to the expanded use of telehealth. In particular, again, as we envision the future of telehealth, what do we need to make sure is maintained? And is there anything still missing?
So there's a lot to unpack there, but I'll try and keep it concise and simple. But in short, COVID-19 has been a game changer with regards to telehealth and future access to treatment. Specifically, the changes in how health plans cover and pay for telehealth have been central to its expanded usage in the past 5 months, and to our ability to maintain access to care and increase access to care for patients in the future. And I think it's to such an extent that I think it's going to be hard to put the genie back in the bottle, because folks are realizing, hey, this is effective, and it's a good option. Keyword being option for patients to have, regardless of whether or not there's a pandemic. And I think there's kind of 4 big areas I'd focus on. The first is coverage parity. So first, during the pandemic, telehealth has been covered and utilized for a much broader range of services than prior to the pandemic. And it's been available in recent months without copays. And this kind of gets at what Marvin was saying earlier about the 90% and 10%, is, during the pandemic, individuals have had to receive higher levels of care, like intensive outpatient care via telehealth, or they've had to attend group-based therapies via telehealth. I think it's fair to say that prior to COVID-19, it was unlikely that such levels of care would have been commonly delivered or received via telehealth, much less covered by the health plans. So it's to be seen with regards to how providers move forward in delivering higher levels of care, and or how patients choose to receive such care after the pandemic. But coverage of telehealth delivery of these services by health plans has obviously been crucial to the expanded use of telehealth, and needs to be going forward. Then also there's the issue of payment parity. Health plans have had to reimburse services delivered via telehealth as if they were being delivered in person. So there's simply a shortage, and Marvin's talking about workforce. There's simply a shortage of behavioral health providers across the country. And the demand for care exceeds the supply of providers able to provide it. And I think in Illinois, according to HRSA, it's somewhere in the range of like 35 to 40% of Illinoisans live in an area with the shortage of mental health professionals. I think at the end of the day, we still need more providers in these areas, but in the short term and medium term, telehealth can be and is shown to be an effective way to close the disparities in access to care. But if this is going to happen, providers need to be able to afford to provide that care. There needs to be the financial incentive there, irregardless of the delivery mechanism. Obviously, in this case, we're talking about telehealth. So, payment parity in the context of telehealth has been and will continue to be crucial if we want to incentivize and make possible the provision of services in areas where there are disparities in access to care. And then the other two things that we've talked about as barriers before, but in this context are about payment and coverage. Again, it's the technology. There's been expanded flexibilities around the types of technology that can be used to deliver and receive care. So we don't want health plans to restrict what technologies they'll cover. Again, the biggest example here is audio only. Thousands of Illinoisans lack reliable access to the internet, or maybe they don't have smartphones, or they just don't have the technological wherewithal to navigate some of these modalities. So health plans need to allow a broad and cover and pay for a broad set of technologies. And then the last thing I'll say again is that we want to, keep up with loosened restrictions on the physical location. In the past, for example, health plans have been able to say, if the patient's in their home, we don't have to cover it. And now there's much more flexibility around that, and we want to maintain that. Again, obviously restrictions on location is problematic. Restrictions on location defeat the entire purpose of telehealth. So I guess, there have been lots of changes in the past 5 months, but I would say the most important with regards to insurance and payment and coverage has been in the areas of coverage and payment parity, and then expanded flexibilities around technology and location.
I would also add something that we haven't talked about is that sometimes telehealth can actually cost more than in-person services because the professional is charging more to do it because you have technology investments that the providers need to make this possible. And so I would say that we need reimbursement that actually covers the full cost of the service, whether it's in-person services or whether it's telehealth. And I think that there is a misunderstanding that telehealth can be less expensive. And I think it is very market driven. And I think that's misunderstood by policymakers. And I think that's important to think about as we're fighting for coverage, particularly with respect to parity, payment parity between in-person and telehealth. We need to take into account some of the additional costs that might be incurred to provide telehealth.
This is Robin. Is this a good time to jump in with a kind of related idea?
Absolutely.
Yeah. So, law firms are an interesting parallel to this. Suddenly we have lots of associates and partners not working in expensive high rises downtown. And as a law firm is able to have less and less space that it needs physically to have, its overhead is reduced. And then you would think that their charges would reflect that over time. So instead of $400 an hour or $500 an hour, maybe it's $425. I don't know. And Heather's point is well taken. If you have a person who's been physically located, and then they have to buy new technology in order to reach new people, but still have that physical location as a fixed cost, and maybe a receptionist and whatever else they have as fixed costs, then I think there's a really strong argument for parity or an increase even. But if you're seeing what's happening with the law firms, that suddenly they don't have the same requirements for space, that they can provide that service from their home, then you have to, it seems to me, acknowledge the fact that somewhere in that blended rate that supported the provider for providing the service was in fact, you know, the office space itself. And I think it's interesting that in chat, you've had a number of people talking about medical services versus mental health services. And it strikes me that some of these things port more away from the physical office space that you supported more easily, i.e. mental health services, than medical services. So I think the parity argument will change depending on what the input from the provider side is. If it's a greater input, as Heather said, and a fixed place, you know, fixed costs don't change, then I think there's a strong argument for that. But I think you have to kind of engage, like, is this going to, in fact, bring down the cost of the provider and keeping open their office? And if it does, then I think that's going to show up in rates at some place.
And I just would like to chime in on that a little bit too, in part because of the population that Threshold serves. And it's been raised actually on a number of webinars that there's sort of this, I think there's a little bit of a fear, oh my God, if we make the argument for expanding telehealth, then the payers, whether it's Medicaid or commercial, will say, well, you don't need the physical space. Telehealth can be extremely valuable for millions of people across the country, but the population in particular that has really serious mental illnesses, who need most of Threshold services, over 80%, are not provided in a clinic setting. We go out to the person's home, we meet them in the community where they're most comfortable receiving services, and that is where we provide the services. But we have locations all across the city for our staff and for clients who receive services in a clinic space. And telehealth for the population that we serve is limited. Right now it's invaluable because it is the only safe way in a pandemic to prevent the spread to our clients and to our staff, unless people really need face-to-face services. But there is a huge swath of people that will continue to need in-person services. So I think we're putting the cart before the horse in talking about, well, maybe we won't need the physical plant. Right now, I think we're trying to make the argument that telehealth is an extremely valuable mode of service delivery, and that we ought to harness that, when in fact we don't have enough access or enough clinicians of any type to serve the people who need the services. And that's what we should focus on. I think that when you start talking about, if we do more of this, we reduce the cost of this. We in fact don't know that yet. And I think we also don't want to discourage providers from delivering telehealth because there might be a negative financial consequence, because providers already have zero margin. It's mostly negative in the Medicaid space. So I just want to throw that out as a word of caution.
Yeah, Michele, can I jump in for a minute? Because
yeah, please do. I wanted to encourage everyone to comment on this. I think it's a really critical conversation. And so anticipating pushback from payer sources that may not fully understand the environment within which our clients exist and our providers exist is really critical. So absolutely.
Yeah, I think with Medicaid, with Rule 140 services, as I mentioned earlier, they have the delivery mode of telehealth or phone and video, and that's the pay or the rates are on the same par as face-to-face. So there is no change in Medicaid. Now, the fear is that because people might look at telehealth as less than a face-to-face service, that they might start to think that they can reduce the rates. We think that's a big mistake, of course. I also wanted to touch on what Heather just talked about around, because she works with clients and her agency works with probably the most difficult clients to work with. And we call them in the ACT program, Assertive Community Treatment. And I can also talk a minute about what clients struggle with telehealth or does not, they do better with face-to-face services. Number one is children. Our members who provide children mental health services have struggled with trying to provide telehealth services to those kids. Just imagine having a kid sit in front of a screen for, half an hour, 15 minutes even. It's a struggle. And, they come up with different therapies or therapy games to play, but still it's a struggle. Another one is substance use clients early in recovery. And I think Robin mentioned that telehealth is difficult for clients early in recovery or early in treatment. Also, newly diagnosed psychiatric clients is another category. And high acuity client, this is the client that Heather was talking about that might have severe and persistent mental illness, schizophrenia, bipolar. In our experience, clinicians need to see these clients' daily activities, their hygiene, changing clothes, whether they're hoarding things. They need to lay eyes on these type of clients on a regular basis, or else they're going to end up in the hospitals or emergency rooms. Of course, those who struggle, again, is those without internet services or phone services, and particularly those with on government supports like SSD, SSI, disability, with that have very limited income and don't have the data or on their phones or enough minutes. And then another one is older adults, where they can be trained to use telehealth or, but still, it's a struggle with some of them. And then homes with children where there is a history of child abuse, those probably do better with face-to-face services. And so there's a list of where we're starting to see that it's not a cure-all for every population with mental health or substance abuse.
Thank you, Marvin. I'm looking at the time, and I do want to make sure that we have plenty of opportunity. This is not a webinar, it's a forum, so we want to make sure that there is audience engagement as well. And there was one other thing that we wanted to cover that I will defer to David if you feel like it's already been covered or if you would like to talk about this a little bit more. But we do realize that there are some changes that will need to be implemented to embed telehealth in more of our long-term future, including some legislative changes. And I know, David, you've spent a lot of time looking at the the lay of the land and where the laws are and where we will need to focus on action so that all the things that we've talked about are appropriately represented in a more long-term vision of telehealth. So is there anything that you'd like to add on that topic? You've talked some about the payment structure, but I want to give you a chance to flesh out the legal landscape a little bit more, and then also tag team so Robin can talk about specifically some of the privacy issues that we also need to keep on the table.
Okay. Yeah, and so as I said before, the genie's been let out of the bottle, and I don't think that we're going back, and there's been a lot of movement at the national level and at the state and local level on telehealth. And with Illinois in specific, I would say that prior to COVID-19, Illinois was perhaps in the middle of the pack or maybe even a little bit behind on certain aspects of telehealth policy. So for example, there are numerous states that statutorily require payment parity between telehealth and in-person. Georgia, Minnesota, California, I think starts in 2021 and numerous others. And then also of the 40 states that have, of the over 40 states that have commercial telehealth provisions, Illinois is actually one of the few whose current statutory language doesn't truly mandate plans to cover services via telehealth. So that's just to say there is legislative work to be done. And I think that we're starting to see those changes at the federal level. There's definitely advocacy. I saw one of the questions in the Q&A box. And there's advocacy at the federal level with national organizations to require that self-insured plans regulated by the by the U.S. Department of Labor are required to cover telehealth. And then I think there's definitely an appetite in a lot of state and local governments. I think we're certainly seeing that here in Illinois right now and in other states too, whether it's through administrative actions, that in the form of executive orders or rules changed, or even just recently, I believe it was New Hampshire just passed a law sometime in the past couple of weeks that mandated coverage parity and payment parity.
And can I just add a little quick point on that, David? And you touched on it already, of course, but with ERISA, you know, regulating the private health plans and, you know, there's a connection to the ACA, but that's a federal game as opposed to a state game. And so to get the biggest, you know, outside of the federal programs, Medicare, Medicaid, and have both been talking about Medicaid, you know, but in the private plans, that's going to be really a difficult thing to do without the federal government. The states they can't preempt ERISA, and so that's going to be at CMS. And that's why I think starting where Michele did with Secretary Azar is really important, because if the feds are already moving that way, then that's a great barometer.
And I'll just make a couple of comments. We really don't have time to flesh out all of these details, but I think it's worth putting together a little bit of a list. That there is congressional action needed to maintain reimbursements, HHS in terms of codes and rules around virtual check-ins and anti-kickback rules that continue to allow no co-pays. That is certainly something for us to look forward to. Right now, the DEA is permitting prescribing controlled substances via telehealth, including buprenorphine, which has been very important for quick access for those individuals with a substance use disorder, particularly those with an opioid use disorder. The FCC is involved with broadband deployment, so being aware of how that impacts our efforts. Individual states obviously are doing the licensure rules, the technology definitions, and also the Medicaid payment, the state contracts for that, as well as departmental. So in Illinois, we have SUPER and the contract policy manual that could certainly be updated based upon some of the things that we've learned during this pilot, I'll call it a pilot program to make sure they're memorialized for the long term. I'll also, wearing my attorney list or hat, add to the list, making sure that there is a viable means for electronic signatures. So I know in the temporary orders, there's the assumption that we will be back in person and we will catch up with the signatures. So that was very helpful to temporarily lift the signatures, but we probably need a long-term opportunity to discuss what is a recognized electronic signature that would be enough to complete the record. There are many others, and again, with time growing a little bit shorter, wanted to make sure at least those general topics were kind of out in the open. So with that, I would like to transition over to questions from the audience. I have a couple, actually many that were submitted in advance. A couple I'm going to look to see, and we'll just ask for some quick answers. A lot of these questions are a little bit more detailed. We'll start on the ones that were submitted earlier, and I think Tina is going to help us sort through the ones that are being submitted now. Marvin, there was a question about healthcare professionals and what are their attitudes toward telehealth? Do you have again, keeping these short, we have about 10 minutes remaining. Do you have a response to that you would like to share? I think you're on mute.
Thanks. Michele, I think it varies. I think it, overall, most of the clinicians that we talk to in our organizations are okay with providing telehealth. I think you have a select group that's starting to emerge that is getting tired of being in the house. You know, I mean, they just are. And they want to get back into the office. So I think it's a combination of both of those right now.
There was a question just in general that asked about privacy and informed consent issues. Robin, did you want to give us some feedback on that question?
Well, you're seeing in chat already the difficulty that a number of people are having around the issue that you flagged, Michele, which is the electronic signature. So it's hard to consent people unless they see the form. You know, we have some technological fixes. We're doing an actually interesting journaling project at IGPA, asking, you know, citizens around the state, or residents, not citizens, around the state, to tell us about their experience of COVID-19. And we're emailing consent forms and then having them, you know, sign them with DocuSign. And of course, we don't have the hyper regulation that you have in healthcare. In a sense, you know, we're where things are during COVID with some of the rules suspended. Like we can, you know, push these documents back and forth between ourselves and get them signed that way or uploaded to a web page that way. Harder, far harder in healthcare though, because of, you know, HIPAA privacy rules, you know, what have people consented to, the storage of those things electronically if you don't have the physical form, you know. And then I think really difficult is privacy. You know, one of the folks in chat was talking about a session she just did with an 8-year-old, I think it was, you know, and he, well, he's hyperactive and sometimes he was off camera. Well, there's a whole lot of things off camera. You don't know if there's another person there. Your you know, client may not know if there's else in this room with me here, for example. So I think, you know, people would need to go back and audit their own consent forms about whether they can make guarantees of privacy. If we're in the 4 walls of the space where you are right now, Michele, I can just look around and for the most part, I understand whether my privacy is being respected. So I think it pushes the envelope for us to have to think harder about that. One happy note I will make about the notes and comments with DCFS, you know, they, I think one of your attendees was saying that they wish there was more flexibility coming back from DCFS. And we at IGPA had done a spotlight on the plummet in the child abuse and neglect reports recently. Why is that? Why is that happening? And I think partly it's because so many students are suddenly unseen by their teachers because of the digital divide that we talked about before. And the reason I mention that is we then use that policy spotlight as an opening conversation with DCFS and with lawmakers. And then we've been in dialogue almost weekly since it's happened with ideas about, you know, how can we shore up families at a time like this when, you know, they have so many needs. And that's been a very positive, constructive thing. So I would say out of this, you know, forum, you know, there would be probably a lot of interest with DCFS to explore that with providers. How can they, you know, get more access for children who need that right now?
Robin, I think before we answer other questions, I do want to make a couple of comments about the purpose of today's forum. I often sit in meetings where we're coming up with great ideas and wondering how are we going to get this built into the system. And so one of the things that we are planning to do that's not typical from one of these remote forums would be to develop a one-pager, which from all that we've been talking about may take up more than one page. We started as a panel just brainstorming things that should be included on that one pager, but not necessarily having all of the answers, but making sure that we have the boxes listed that need to be addressed. And I think there is a lot of quick thought and urgency to formalizing telehealth, but we don't want to be so quick that we leave some of these issues not addressed or unanswered. And so I think the conversations in the chat box and even conversations here are highlighting some of these. We have some fairly firm answers. Others are clearly on the list of things to do. Figuring out a viable remote way to have, for instance, informed consent and documentation and ensuring privacy. Part of it is setting up some standards. Part of it is training, as Marvin indicated before. Even though the provider is credentialed to provide services, when you're providing services on a different format, there are some nuances there, some of which help the clients, like Heather noted, being aware of a client environment if you can't be there with the client. Others could be engagement and learning different techniques for engagement over a remote platform versus something in person. So we'd just like to state that. Also, Marvin indicated that we have compiled a list of resources that we felt would be helpful to share with the group. And so we will be coordinating with Nancy and others to make sure that we share the list of resources that were mentioned today, as well as some others that we've thought of, and push that out to participants as well. So I wanted there to be an awareness that we do want this to be the start of a conversation, and also ideally for the list that we've generated today to be made available to others. We all sit on different seats at these tables at different times. And so while each of us may have areas that we know in more depth, we want to make sure that anytime there's a conversation that all of these topics are well represented. I'm seeing the envisioning slide go up, so I think that might be a signal that Nancy is ready to close up the forum. You know, we talked about how long of a forum with Zoom fatigue and everything else, you know, like what would be an ideal length, and we decided 90 minutes and the time flew by. So I'm sure there are lots of other things we could talk about. Nancy will help us address some of the questions that were in chat box that we didn't have a chance to share with the group today. But I want to thank everyone for being a part of this discussion and encouraging everyone to continue to keep the conversation going. So Nancy?
Yeah, thank you so much, Michelle, and thank you and thank all the speakers. I feel like I went to sleep in the dark ages and just woke up in the Renaissance. I mean, you guys were just absolutely spectacular. You were wonderful, insightful, and wow, a year ago, I couldn't imagine being where we are right now. I want to thank Marvin for his very flattering comment, calling me possibly the mother of telehealth. Well, if I'm the mother, IGPA at University of Illinois is the father, because 10 years ago, they contacted me and said, why don't you look into this thing called telehealth? And I asked them, tele what? And then I spent the year talking to people around the country and saw the spectacular things that were happening. So thank you so much. I want to thank our co-host, the Upper Midwest Telehealth Resource Center and TASC for their superb job, the supporting organizations, the 12 wonderful organizations that got the word out and resulted in this high attendance. We really appreciate this. I want to thank the frontline workers who are making it all happen around the state and risking their lives and their comfort to make sure that people get the kind of care that they need. And as a matter of business, we'll follow up on questions that were not answered. We'll be sending a survey out to all the registrants to get your feedback. We'll be giving you a link to the recording. And I want to thank all of you for attending. I really appreciate it, and it's very exciting. It's a new day in Illinois. Thank you.